Welcome everyone. Let's talk about unconsciousness. An unconscious patient is common presentation to the emergency department, and usually there are different levels of unconsciousness. The emergency department doctor should have a structured approach how to put a differential diagnosis, how to establish a safe monitoring, what are the most important investigations that are directed to the cause of the unconsciousness, and formulate an initial management plan for the patient. The problem is that patients who present with unconsciousness, they have maybe having serious illness or may having serious injury to their brain. They may have different levels of unconsciousness and unresponsiveness depending on the amount of injury and the intensity of the stimulus that you do to examine them. The emergency department physician must be able to treat and investigate patient based on a very limited history, and therefore a good understanding of the conditions that cause unconsciousness is necessary for any doctor who is working in the emergency department. What's the pathophysiology of unconsciousness? So to be conscious, you require two main components of the central nervous system to be functioning. One is reticular activating system, which is situated in the brainstem. The other one is at least one cerebral hemisphere. So at least one cerebral hemisphere should be functioning. That's why a patient with stroke, usually affecting one side of the brain, it does not cause coma. While if a stroke affecting reticular activating system, which is inside the brainstem, so brainstem stroke may cause coma because of failure of the reticular activating system. What are the cause of unconsciousness? If you go by ABCD, in the airway breathing, you may have problems of hypoxia, hypercarbia. Hypoxia, hypercarbia together called respiratory failure. Just by simple pulse oximetry, you can detect hypoxia, and hypercarbia can be detected on ABG machine. So such patients with hypoxia may have anxiety, agitation. Later on, then a severe one may lead to unconsciousness, while hypercarbia leads to a state of drowsiness. Shock patient. If a patient is shocked, whether it's septic, hypovolemic, cardiogenic, anaphylactic, any cause of shock may lead to reduced level of consciousness, then coma. Acute cerebrovascular event. So whether it is a stroke or due to or when there is an epilepsy, especially post-ictal state, dural vein thrombosis, especially those who have thromboembolic diseases and during pregnancy, so all may lead to coma. We say mostly the stroke should be in the brainstem to cause unconsciousness. Another system, metabolic and endocrine, hypoglycemia, hyponatremia, thiamine deficiency, B1, Wernicke's encephalopathy, or hypothyroidism, DKA, uremia, renal failure, liver failure. All these may lead to metabolic problems related to unconsciousness. Infections in the brain, encephalitis, meningitis, cerebral malaria, this all may lead to unconsciousness, especially encephalitis. Drugs and toxins. So there are some drugs that cause a reduced level of consciousness, which suppress the CNS function. Opiates, benzodiazepine, toxins like alcohol, CO poisoning, and also this is carbon monoxide, tricyclic antidepressant agents, barbiturates, organophosphate poisoning. They all lead to a state of coma. So the clinical assessment and management of unconscious patient, the patient should be assessed with standard ABCDE approach, and of course assessment and treatment should occur simultaneously, because sometimes you don't have much time. You may cause secondary brain injury if delayed. For example, if a patient is hypoxic, hypercarbic, hypotensive, all should be treated at the same time at the time of investigations. So because if you don't treat them, they will be worsened later on. So a clinical assessment and management of an unconscious patient with ABCD airway, unless the cause of consciousness is associated with a brief or easily reversible pathology, example post-ictal state or hypoglycemia or opioid overdose. For example, in these cases, you may wait in post-ictal state after convulsion. You stayed for about 15 to 20 minutes, the patient becomes conscious without treatment. A hypoglycemic patient, give glucose. An opioid overdose, you give naloxone. So these are reversible causes. They don't need intubation and ventilation. But if you are not sure about this, you may ask the help of anesthesia. They may need intubation and ventilation. This is to protect the airway, not to increase oxygenation and things like that. And patients who have Glasgow coma scale of 8 and less, they cannot protect their airway from the aspiration. In the breathing, patients should receive high flow oxygen until an ABG determines the concentration of the oxygen that's required. For the circulation, hypotension may be the cause of reduced level of consciousness, and sometimes it exacerbates some other etiologies. For example, a patient with brain injury, if they have hypotension, the brain injury will be increased. It causes secondary brain injury. So patients should be given appropriate fluid and inotropic support if not responded. So you have to stop any cause that causes hypertension. Example, you stop a hemorrhage, you treat a sepsis with antibiotic, you give inotropes and support the heart failure. For the disability, this is the bulk of the problem. That's why you have to check the Glasgow coma scale, the random blood sugar. You also have to examine the lateralizing sign. At the same time, search for other things, and also look for the pupils. Patients who have Glasgow coma scale and pupillary reaction should be assessed regularly. For example, hypoglycemia may be detected by a simple bedside blood glucose machine. If you see hypoglycemia, you can give 10% or 20% or 50% boluses of glucose until the patient gets conscious or their random becomes normal. Patients who have taken an opioid overdose or their history is suggestive or then there is needle track markers, pinpoint pupils, you have to use naloxone, 0.4 milligram bolus. Patients who have benzodiazepine overdose should be given flumazenil, but this should be a clear history of benzodiazepine overdose. Patients who are malnourished, suspect of vitamin B1 deficiency, you have to give thiamine because it leads to vernix encephalopathy. A problem that may raise, which is also rare, if a patient have hypoglycemia and at the same time they have thiamine deficiency, you have to give thiamine, then you give glucose. Because if you give glucose before giving thiamine, you may lead to acute neurological damage. A head injury patient, the priority in patients who have sustained brain injury is to maintain adequate perfusion and oxygenation. So you provide a good airway and breathing and circulation to protect the brain from secondary brain injury after head injury. Acute cerebrovascular event, if there is, most patients who have a stroke do not present with coma, but only those with brainstem stroke should be. Usually, it's not easy to diagnose brainstem stroke, but if you do an MRI, it would detect the problem. Patients suffering from seizure will have a reduced level of consciousness. By the time you are examining, they may get consciousness within 15 to 20 minutes. This is called post-ictal state. So on exposure, you have to expose the patient. You may see a cause of decreased level of consciousness. For example, you may see scalp laceration, hematoma, basal skull fracture problems, and history suggesting of seizure, example, the tongue bite and posterior dislocation of the shoulder, all these can tell you this is the head injury. A patient with fever, rash, neck stiffness may be due to an infection because of meningitis. A patient with needle stick mark dry skin may suggest a tricyclic overdose. A cherry red skin may suggest CO poisoning. A patient present with profuse hypoglycemia may be due to profuse sweating, may be due to hypoglycemia or organophosphate. So all this can tell you that the toxin was the cause of unconsciousness. So once the ABCD assessment has been performed, then the direction should be to a detailed neurological examination. So after you have done, you may call a neurologist or you have to do a neurological assessment. The investigations should be directed to the most common cause of reduced level of consciousness. So careful clinical examination. If you do a good clinical examination, it tells you what investigations you have to do. But for all patients, you have to do a blood glucose. So the first and most important blood test to do bedside for a patient with coma is blood glucose, because it can tell you a rapidly reversible cause, which is hypoglycemia. CT scanning is very useful in patients with unconscious patient. However, sometime in some patients you cannot reach the diagnosis with just a CT scan. You have to base on some other examinations. For example, a hypothyroid patient, you may send for a T4 TSH and the patient is having history of thyroid problem. A DKA patient, you may send for ketone in urine and VBG. Post-ictal patients have a clear history and have tongue bite. So you send CT scan for this patient, it would not give you any hint. Also, other patients like hypoglycemia, opioid overdose, you just reach it by history and diagnosis and high suspicion. CT scan may help you when there is an intracranial hemorrhage, or when there is a skull fracture, or when there is air in the intracranial region, called pneumocephalus, hydrocephalus. Diffuse cerebral edema maybe sometimes can be detected. IBG may show you hypoxia, hypercarbia, acidosis. So an anion gap may suggest a toxin or a metabolic problem. Other investigations should be directed according to the clinical picture. Usually, basically, you have to send for full blood count, renal function, serum electrolyte, blood culture. So each one can give you an idea. For example, there might be an increase in the YBC. There might be in renal function increase urea, serum electrolyte disturbance, especially sodium and calcium and magnesium may cause problems in conscious level. Blood cultures are directed to the problem, and chest x-ray sometimes. So unconsciousness may be due to failure of the reticular activating system or both cerebral hemisphere. Patients should be managed in an ABCD approach. While you are examining the patient, you have treating the patient at the same time. Hypoxia, hypotension, hypoglycemia are common causes. Patients who are malnourished should be suspected of having IV thiamine deficiency, for thiamine deficiency, which causes vernix encephalopathy. Patients who are suspected of having opioid overdose based on respiratory depression, pinpoint people should receive naloxone. And also patients who have a clear history of benzodiazepine overdose should receive flumazenil. A raised anion gap may give you a toxin or a metabolic cause. And the reduced level of consciousness plus pyrexia, you have to start with antibiotic because it might be meningitis or encephalitis based on the clinical picture. Thank you so much.